11:11?
1:11.
It's 1:11, sorry. I'm still on California time. Is it better? Not really. I don't. It's on. How about now? Okay. I'm going to call the meeting to order. It's 1:12, and I'm going to invite Reverend McDonald up for the Pledge of Allegiance and the prayer also as well.
Let us pray. Gracious God, we invite, invoke, and welcome your presence. Thank you for every mind and heart gathered in this place. As we turn to the work before us, calm our distractions and center our thoughts on what matters most. You have entrusted us with gifts of time, skill, and wisdom. Guide us to work together with respect and unity, making choices that are right and fair for the John Peter Smith Hospital Network and the communities we serve. The people of God said, Amen. Please stand and join with me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Thank you, Reverend. At this time, we're going to do the swearing of our new board officer, Mr. Dustin. I guess please raise your right hand. I state your name.
I, Dustin Austin,
Do solemnly swear and affirm
do solemnly swear and affirm
that I will faithfully execute the duties of the position in which I've been appointed
that I will faithfully execute the duties of the officer's position to which I have been appointed
by the Tarrant County Commissioner Court,
by the Tarrant County Commissioners Court,
and I will do the best of my ability
and I will do the best of my ability
carrying out such duties
carrying out such duties
in a manner consistent to the Tarrant County Hospital District bylaw
in a manner consistent with Tarrant County Hospital District bylaws
and the law of the state and the United States.
and the law of the state of the United States.
So help me God.
So help me God.
Congratulations,
Thank you, sir. Appreciate you.
Mr. Roger?
That did not match.
That's what he just said. Go with DTs.
Okay.
Sorry.
You have to redo it like President Obama. That one's got elected and all kinds of stuff in there.
I state your name.
I, Ellen Roger,
Do solemnly swear and affirm
do solemnly swear and affirm
that I will faithfully execute the duties of the officer position to which I've been elected
that I will faithfully execute the duties of the office position to which I've been elected
by the Board of Managers of Tarrant County Hospital District,
by the Board of Managers of the Tarrant County Hospital District,
a political division of the state of Texas,
a political subdivision of the state of Texas.
and I will do the best of my ability
I will do the best of my ability
to carry out such duties
to carry out such duties
in a manner consistent with the Tarrant County Hospital District bylaw
in a manner consistent with the Tarrant County Hospital District bylaws
and the law of the state and the United States.
and the laws of the state and the United States.
So help me God.
So help me God.
Congratulations, sir.
Thank you.
Okay. And at this point, I would like to invite our new board member, Mr. Casey Ford. Let me make sure I got the right one. I state your name,
Casey Ford,
do solemnly swear and affirm
do solemnly swear and affirm
that I will faithfully execute the duties of the position in which I've been appointed
that I will faithfully execute the duties of the position of which I've been appointed
by the Tarrant County Commissioner Court,
by the Tarrant County Commissioners Court,
and I will be the best of my ability
and I will be the best, due to the best of my ability,
carry out such duties
carry out such duties
in a manner consistent with the Tarrant County Hospital District
in a
bylaw
manner consistent with the Tarrant County Hospital District bylaws
and the law of the state and the United States.
and the laws of the state and the United States.
So help me God.
So help me God.
Congratulations, sir. Welcome on board. Yes, at this point, would you like to address to get the board and the people to get to know you a little bit?
Hey guys, Casey Ford, thank you for having me on the board, appreciate it. My background is I'm a CPA, was at Baylor University. I grew up in the area in Tarrant County, so got to be contributing, to this great county. Currently I do private equity, do tax structuring planning, and help out on, a bunch of other things here and there. So appreciate y'all having me and look forward to serving y'all.
Welcome on board, sir. Thank you. The next item on the agenda is the approval of our last minute. Any comment, concern? If not, entertain the motion to approve.
Those were approved at
Oh, they were approved?
the September 11th board meeting.
Okay,
Yes.
so nothing here. Next item is the fiscal, welcome, CFO.
Maybe. Good afternoon, everyone. Lanny? We will go over the fiscal '26 budget, the revised budget, as updated based upon the change in the approved tax rate by the Tarrant County Commission this past week. I do want to bring forward a few things to round out the approval of the budget. So, because if you had the opportunity to listen to our presentation, there were also some other things presented that I would like to make sure that the board has an opportunity to hear about and really understand the story behind some of the things that were discussed during that time. This does start on page 5 of the portal packet. So, as a reminder, when we put the budget together, we balanced not only the strategy, which is on the left side, access, workforce, financial, sustainability, with all the external forces that we have. So state, federal, local, you name it. We have environmental. COVID was an environmental threat to us. So we're balancing all those through a budget process that is worked through from the bottom up. We look at the volumes, the services we need to serve for the organization. We then develop the revenue and expenses, the operational changes and initiatives required, and then the capital investments for the organization. So this is a process we take. We are starting a long-term planning process to develop a 10-year financial plan. We have refreshed that this year, and so this is the foundation, the budget for '26, under which we will develop that. So at the commission meeting, it was shared about our financial performance, actual against budget. What you have in front of you is a chart that shows blue bars, which are the budget for the year, and the green line, which is the actual performance. What was shared at the commission was fiscal 20 forward. COVID, as you can see, is right at fiscal 20. COVID started at the end of our fiscal 20, or excuse me, in the middle of our fiscal 20. And it shows you the gaps in performance compared to budget. And what I want to do is show this board. I want to give you the story behind these gaps so you understand what happened during those times that was not we couldn't project when we were doing the budget. So we're going to take the 3 years of COVID first. So COVID started in 2020. We had a budget of about $30 million. We had about $52 million of COVID relief that came in that year. I will make a comment about COVID relief. There were various buckets of COVID relief dollars. There was CARES Act provider relief dollars. There was HRSA reimbursement for self-pay. So there are various relief funds that were available at state, federal as well, and multiple federal agencies. And so 52 million in 2020 alone. COVID again started mid-year. COVID dollars were dollars that we could not budget, and you'll find that during these 3 years. We just didn't know. CARES Act money, we had to reconcile our costs against that. HRSA, we were submitting based on the self-pay patients who had COVID. That's what we would get reimbursed for. This isn't unique to JPS. This is across the country. And so it was always a challenge, like what are we going to get next to help us during this time, unprecedented time. So in 2020, we had COVID relief about 50 million. Also in 2020, the Medicaid uncompensated care was rebased, recalculated. So with one change, we got $100 million in uncompensated care, supplemental care from the state. So that was one change we didn't know when we did the budget. So a huge change. We had some volume and mix, and when I say mix in these slides, it has to do with payer mix and types of services being provided. And then there's about 25 million of other things. But the purpose of these is to really show you the big things that contributed and could not have been foreseen in a really good calculation as we were doing budget. Some of it we didn't know because we usually close the budget out at the end of July. And many of the federal and state initiatives we learn about in August, September, October. And so we have to make our best estimates. 2021, similar, we got almost $150 million in COVID relief. Medicaid supplemental across the other programs such as DISH, 35 million, and then volume and mix, about 58 million. 22, we got another $50 million of COVID relief, increase in Medicaid supplemental, and then we had a negative on volume. Keep in mind, fiscal 22 is when the largest surge of COVID occurred. In January of 22 is the largest 800,000 cases a day in this country. That was the largest month. So from December, in the winter of 21 to 22 was the largest surge of COVID across the country. And remember, during COVID, a lot of elective services were deferred. And so we were really taking care of the sick, the medical patients versus the surgical patients. We were seeing surgical patients once some of the moratoriums were lifted, but we were seeing. So during COVID, these 3 years, we got $250 million of COVID relief funds. Just keep that in mind as we look at those variances. Then we get past COVID in the last 3 years, including this year. In 2023, we had an increase in Medicaid supplemental. This was a mix between HARP and DISH. Volume and mix, volume started to come back. We also had investment income, and this is investment income less our interest expense. It's a net number. But investment income in 22 was low. We had a surge or a pickup in investment income in 23, and then some other smaller things. In 24, same, we had another pickup in Medicaid supplemental. We had volumes were continuing to grow post-COVID. We had investment income again performing well. Again, we're a little unsure during these times. And then for this year, again, which we had gone through at the last meeting, we had one-time impacts. These are those one-time recoupments that we talk about $46 million. Medicaid supplemental is a negative this year. If you might recall, we had a negative $60 million impact to the budget for DISH this year. And then volume is up. Volume continues to be up. We continue to improve with throughput initiatives around the organization. And so there's always, when I show you these 6 years, there's like 3 things or 2 things that really contributed that we couldn't really foresee or forecast accurately in the budget. So I wanted to share this with the board so that you understood really what was going on during those years in the story. As we move forward, there's some question about investment income, and I mentioned in 22 the investment income was low. It was about 0.6%. Fiscal 23, it improved. We're at about, through June, we get quarterly reporting on our investment income, about 4.48%. That is equivalent to what the county, Tarrant County actually also is getting on its returns. They are actually at 4.49%. And for the budget this year, we budgeted 3.79. We talked to our investment advisors at the time we were doing the budget. They felt there was going to be a 100 basis point adjustment in the Fed at that time. Probably about 50 at this point in a discussion with them a couple weeks ago. That would probably add another 10 million to the budget if we were finalizing the budget today. So just want to be clear, about 50 basis points, based on our cash that we have today, our investments today would be about another 10 million with 50 basis points. But I wanted to explain why the investment income perhaps might be a little higher this year, depending on what happens with the Fed. So this is a graph that you saw when we went through the draft budget and the budget approved at the 17417 tax rate that we used as an assumption. Again, the blue represents the maintenance and operations portion of the ad valorem. The darker, which you see starting as a bigger darker in 24, is the interest and sinking fund or the debt obligation. And the green number above is the total of those two numbers. So in the red box, the first set is the budget that we presented that had the assumption of a tax rate of 17417. The county commission set the rate at 1650, which lowered that by about 27 million. Any questions on that? Our operating performance will be going from a 2.9% operating margin to a 1.5% operating margin. We are adjusting our financial performance by the change in ad valorem for next year. You'll see at the bottom the future fund balance that we'll be able to grow to about 1.7, short about 27 million, because that's equal to about what the ad valorem went down by. And so we'll continue to monitor this and how the future fund will grow, and I'll just show you in a minute with a draft long-term view about where we're going around the future fund build, and the future fund right now designated for the master facility plan. I'll show you right now, sorry. This is a draft, and I want you guys to know it is a big draft. This is based off the long-range plan that we have developed a few years ago with some updates. It shows you in that top green line operating performance. And I looked at what our operating performance needed to be in order to reach the $2.5 billion mark by 2030. We need to achieve a 2.9% operating margin. To achieve that 2.5, that assumes that interest income continues at a 4% rate of growth. With investment income, I also wanted to show you how the contribution of investment income goes down as we spend the money. So we're at 90 to 100 million going towards a future fund or performance right now. By the time we build and open the hospital, we will be at half that number. So I just want to share that with you. We will be updating this plan this year, and when we present the budget next year, we'll be showing you the long-range plan that goes along with the budget as the foundation. So with all this information, this is the income statement. The red box is the revised budget. You'll see what the only line that has changed is the ad valorem tax revenue line. We had set the rest of the budget fixed at the end of July. So we are asking the board to approve the fiscal year 26 revised budget as presented with the revised tax rate of 1650.
Fund balance, there's an asterisk that says it includes the $350 million debt. And then I guess in 27 it's going up by almost 400 million, you're assuming we issue the second tranche of debt.
That is the 350 is the second tranche of debt.
Okay, and that's why there's a big gap.
Yes.
And then after that it's just
Operations funding that. Perfect, thank you.
Any additional questions before we vote? If not, I entertain a motion for approval. favor signify aye. Aye. Any opposed? Motion passed. Thank you, Kim. Now we're going to get an update on our master facility plan from Brian and Mr. Ramon.
Good afternoon. For those new, I'm Brian Geyer, Vice President of Facilities. Introduce Ramon from Ramel Companies, who will provide the update on the Master Facilities Plan.
Good afternoon, everyone. Ramon Guajardo Jr. with Ramel Company, working with JPS on the Master Facilities Program. So let's get started. Starting off with the Psychiatric Emergency Center. As we're all well aware, we went live and opened on September 17th. Fully operational. Very proud of that moment. It's the second facility underneath this program that y'all have now opened, so congratulations to you all. Had a great event. We worked through our activation to be delivering the project on time. We had a great open house sessions that I know many of y'all attended, and it was very well received by the community and, of course, those that rely on those services. So again, that project is closed up, operational, and we're in the process of decommissioning the current Tower 10. So congratulations, y'all. We've made it too homey there for her. All right, moving on to the parking garage. As y'all all know, that scan is going on very, very fast. As we know that the St. Louis elevation is completely wrapped. They got all the screening on the building. Now they're working on Magnolia. At the time that I reported this, it was 50% complete. They're probably close to 80% complete now. So we're working on, getting ready for the go live, which, looking at go live spring of 2026. So right now we're working on kind of our parking strategy, working with the parking committee and identifying the operations of the actual parking itself. As we all know, this will be serving the Health Center for Women parking. It'll be serving the visitor and patient parking for the hospital, JPOC, and MOB, as well as our staff parking as well. So 2,500 spots, if y'all don't remember, so it's a very large space. Moving on to the Health Center for Women, this is the retail space within the parking garage. It consumes about 20,000 square foot of the retail space that is along Magnolia. Right now, we have completed the design development phase. We're finalizing it right now and moving on into construction documents. So what we're looking at is we are looking at submitting for building permit late 2026 and starting our construction, 2025, sorry, and starting our construction early of 2026. So this project is progressing well. We're staying ahead of the game because we know that we need to have this operational by the end of 2026 in order for you all to move your services from the current location into the brand new facility. So it's going very well.
So is it on the first floor?
It is. It is on the ground floor. It actually is on Magnolia Avenue. So it's got a little drop off there, and that will be the kind of storefront. Majority of the people will be coming from the parking garage because it does have a dedicated parking on the first floor of the parking garage.
Is the construction different to seal off the fume and all that stuff?
So no, so the actual the building itself will be built by the garage team, and then the other team will come in and do kind of the finish out of it. So yes, it is a separate building. It's not like it's part of the actual garage. It has its own roof, if you will, and its own exterior walls. So yes, the fumes and stuff like that, rain, will be very well sealed from entering the building. Yes, sir.
So what else going to be housed here? It's obviously OB-GYN services, mammography, ultrasound.
No, the mammography and ultrasound will be in the MOB with the other radiology services. Yeah, I mean, there'll be MFM, sonography, but not general sono.
So just patient rooms, like
Exam rooms, exactly. Yep.
And that's a great segue because we go into the MOB, so where some of these services are. So we have completed the schematic design. We are currently in the design development. We've actually completed Super Week 1 and 2. We are actually getting to the point of having some departments sign off on some of the design documents under DD, and then of course we'll be moving into construction documents after that. Right now we have released the first initial guaranteed maximum price, which is the first kind of work towards this project. As you can see, you all have approved $40.1 million, and really what that is going to start, it's going to start our site utilities, get our foundations for our crane, and then our foundation and concrete for the building itself. We're also going to be procuring the long lead mechanical equipment and electrical equipment that we're always up against. So those are the initial packages that'll get us going in order to stay on schedule. Yes, sir.
Comment. At our budget meeting, we talked about possibly adding a floor.
Yes, sir.
Building. This is gonna be at maximum capacity the day we cut the ribbon. Is there any more talk about that, or is that still flexible, that if you wanted to do that, it could be done?
Yes, sir. Oh, go ahead.
Yeah, I'll say right now, we're contemplating adding an additional floor. We're really evaluating where that additional floor needs to go based on the services that are in there. So yes, we are in the determining that phase.
I would recommend putting the additional floor on top.
Yeah.
And there's a lot to it because
Well, what we're going to put where. So if the shell space should be at the top, should it be somewhere in the middle based on future growth? Because we have to consider what are we looking at potentially growing in the future. So we want to make sure wherever that shell space is allows for adjacencies around it to grow appropriately.
We will bring it back to the board because we still want Kim to do the financial modeling on that and make sure that the board is approving.
Okay, I just wanna make sure we weren't locking ourselves in,
The good news is a shell space is you're not designing anything, and so it's easier to add.
And yes, adding another floor to the current design is not a challenge. They can add it quite easily. But yes, nonetheless, we still have to have that decision made. So yes, sir, we'll be bringing that information because there are a little more things that go to it rather than just adding a floor. So we'll be bringing it for full evaluation. All right, moving on, central utility plants. We have completed the schematic design. We're currently in the design development. Again, we have already released $127 million to start our work. Again, that's going to get set up our temporary electrical services, water services for the project. It'll start the demolition. We start actually moving existing utilities out of the way in order to go vertical, start clearing the land, and again, as we all know, releasing the mechanical electrical equipment that has long lead items. So that's where we are right now. Moving on to the new hospital. As you know, we've already completed the schematic design. We have already completed Super Week number 1 and 2. Our design is progressing very well. As you can see, we still have concept on some of these renderings, but we're getting to the point where those are going to get locked in very soon. We have page turns very frequently to go over decisions that need to be made, and the design is progressing very, very well, and we'll be coming to y'all with some different images and things like that as those renderings get hardened, if you will. Our current construction right now, you're going to start seeing fencing going up in a few weeks. That's going to be the first real break of the ground, if you will, for the hospital. The work that we're doing, of course, is the relocation of site utilities in order to build our 1 million square foot hospital. The relocation of the ambulance bay. The ambulance bay needs to move a little to the west in order for us to start working and digging the hole for the lower levels. And then again, relocation of support systems. I mean, very simple things like docks, compactors, where deliveries are made. That's a lot of coordination that needs to go in because we're shutting down that dock. And so we've been actively planning how those operations will continue to work without skipping a beat on providing the services to our patients.
So, since we're in our finance and planning side right now, I'll ask the inverse of the question that Blake just asked, because I think we talked about this in the committee, we had our whole weeks together. I mean, are we sure, you know what I'm gonna ask, are we sure that we have value engineered this thing to the point that it's not going to, number one, get more expensive, but number two, that we're not building, not being a construction guy, we're not building more hospital than we need, we're not building more, you know what I'm asking?
Yep.
Answer that. Yeah, I mean, I think you're right. Value engineering, and y'all can chime in, goes throughout the entire process. And so it's happening today. It'll happen until we finish, as we're selecting items and looking at our options, and y'all can weigh in on that as well. Second thing, you know, from a KPU standpoint and how many beds are we building, you know, we do have the opportunity, don't have to make the decision today. I think, you know, you hear every day that we're holding, our volumes are up, and all those things. But in the future, we will have to make a decision if we are going to build out shell space. Right now, we have shell space contemplated, you know, in the hospital, but, you know, 5 years from now, 4 years from now, I can pretty much guarantee you we would fill every single spot, for sure, in the hospital.
Well, and I know so much of this is probably set by JACO or some of our planning agencies, but, I mean, these are beautiful concepts. Hospitals will be proud of, a hospital that we deserve. I'm just wondering in terms of materials and savings that's available there, we're looking at all of it.
Yeah, so like Jill said, you know, value engineering continues on. Even standardization of things, you know, going anywhere from, you know, 1 monitor, 2 monitor in Utah times 12 floors, it's a lot. So we are looking at those standards, making sure that operations is being delivered with the equipment that they need in order to provide the services, but that we're also not being, you know, we're not costly with regards to that equipment. I think as far as materials, I think, yes, we're trying to get as, number one, light with materials so it's not heavy structure, but also how much can we standardize in the sense of manufacture offsite in order to bring in and put in place rather than all this build in place. So we're working with the teams on how to do a lot of prefabrication off site, because working up in the air versus working on the ground is a much different cost level. And so we're looking at several different strategies in order to mitigate cost overruns. And we do enter in the approach of we're always looking for savings, no matter if we are in budget or not. We know how construction goes, and we know how just the economy can go, and we need to be able to pivot, not only pivot, but absorb at any given time. So yes, sir.
Yeah, I mean, just given the history of this project, I mean, you guys bring us the GMP on this. That's what we wanted to do.
Understood.
Yeah,
100%.
and you bring up a good point, because we do have regulatory requirements, obviously, that we have to continue to follow. We also want to look at durability. We don't want to make too cheap of a choice and be replacing, for example, a floor, right, in a year or two. We're very hard on facilities because there's so much traffic and so much work that is done. It is a balance for sure.
But I hear you loud and clear.
We'll keep asking that question.
Yep.
Financial planning from now.
100% understand.
On these, on the contract amount, what are you using or intend to use? Well, actually, the one for the new parking garage, how are we tracking what we're spending with our small local business, our trade partners?
So the parking garage is a project that we kind of inherited, so we didn't necessarily have standards or something like that, a tracking mechanism. So I can't say that we really have great standards for being able to track that right now to answer your question on the new garage. But I know going forward, that is a different take that we are having. We are establishing not only just how we're tracking, but it's also the outreach. How are we facilitating our outreach to the community? You know, it's one thing to have a database. We all have databases. But there's a lot of people outside of that database that want to work here, that have the opportunity to work here. And I think that's what we're trying to do is to reach out to as many different partners, community partners that have databases that we don't. So we're trying to utilize that. JPS, a lot of people want to work here. We have a large program here that's very enticing. So we want to get that message out to the community, to those other agencies that can help facilitate and reach out to those others. So we will. We've got a great tracking log on how these other projects, how each of the bid packages go out, who they're going to, what the timing is, and then back of what the responses are. We're also looking at seeing, because a lot of these scopes are rather large, and so they don't always appeal to some of the smaller contractors. But what you can do is break up that large scope into smaller scopes that then allow those to be third tier. And that's what we want to look at. We want to look at how these smaller contractors can get in with the larger ones. Yes, the larger ones may be the one that gets awarded, but how do they break it up? For instance, your mechanical, there is sheet metal. Well, there's a lot of sheet metal companies that do that won't be able to take it on as holistic mechanical, but they can provide those services too. So that's what we want to do in working with our construction managers, is making sure that they're being very broad and not always going to what their database is. Because back to Tim's question about being, cost effective, is that as well. Are we getting the cost effective measure from our contractors as well? And that inclusion sometimes can bring you those cost measures, if you will.
Good answer. Thank you.
Yes, ma'am. All righty, moving on. I think we're at the last page. Yep. This is just a summary, just to give you kind of overall what we've got for all the projects. It's just a snapshot. As you can see, it gives percentages where we are, what our key updates are. As we said, the PEC is opened. It's operating. Our parking garage, we're looking to go live of spring of 26. We're continuing with the skin, working through the MEP finalizations, turning over some of the IT stuff over to our department to build and go live. Our Health Center for Women, you can see where we are in design. We're already going into the construction documents. Same thing with the MOB. We're completed Super Week number 1 and 2. We're really progressing there. And then our central utility plan and our hospital as well. You can see where they are. So, again, any questions?
Thank you for the great update. Thank you for the great update.
I appreciate it. Thank you. Yes, sir. Yes, sir. Absolutely. Absolutely. Absolutely they do, because we have dates that we need to submit to the city in order to get our permitting and in order to start construction, in order to have the correct or the completion date that we're reporting. So yes, the design team is held under a strict schedule as well, and there are several times where we're telling them, we need to do that a little bit quicker. So that is a common theme of ours. Absolutely, we can do that. Let us fold that in next time, and I'll start getting some of those dates of the deliverables of each ones, even the ones that are in the future, because I think this is what we're not showing on some of these slides is the future dates, but certainly we can get that schedule for the design. Yeah, it does. Yeah. Super Week is taking your end users, your clinical staff, and setting up multiple meetings. Sometimes there could be 3 to 4 meetings at 1 hour. And so what it's super is we just hammer through a week of nothing but design meetings, and they're kind of detailed by departments. And so we've got them broken down into departments. We've got our key leaders in there, and we go through the design concepts, what they're looking for end user wise. They get the information, they come back to a summary, we come back and sit down and look at the summary of that until then we move on to the next Super Week. So the Super Week is a bunch of meetings in 1 week. You're talking 1 week, and I'll bet you there is anything from probably 15 to 20 meetings in that 1 week. Probably more than that, but it's quite a bit. It is a daunting schedule to look at.
And a lot of these meetings are by department.
They're correct. They're by department, led by the design team here on site, so we're not having our staff go anywhere off-site or anything. We're being convenient. And sometimes it's over lunch, and we got to bring lunch in and things like that. And the end users are doing a great job at attending and providing great feedback.
Casey, have you been in anything?
Yes, I'm not super.
Thank you.
Thank y'all. Appreciate it.
Madam CFO for updates.
I'm back. The financial report actually starts on page 28. I actually have just a few slides to talk about the financial performance for August for this fiscal year, which is the 11th month. Next Tuesday ends this fiscal year. So we'll be starting on Wednesday for the new fiscal year. So, whoa. One press of the button took me all the way through. We're done. Not really. All right, so really what's been driving the performance for the month is we have volumes, and this is not a new story to you. We have been busy all across the board in the organization. The pharmacy continues to grow, particularly in the specialty pharmacy area, and we've been actually continuing on our path of managing expenses in the organization, including looking at reduction in contract labor, reduce shift incentives. We also have some non-labor initiatives going on in the organization. And we've also had a favorable pension adjustment this year, which is subject to the measuring period for the pension plan every year. We've also had this month, we had some supplemental relief. We had the final Medicaid uncompensated care calculation for this year. We budgeted $108 million for that. We received notice of $120 million for the final payment. So you'll see in a moment that we recognize through August, in August. So about 12 million of that did not relate to the month of August, but it does relate to the year. And so you may ask the next question, what did we budget for next year? We budgeted 120 million. So it was our best guess. Apparently it worked out okay. So
The question is this the same category that we significantly short the current fiscal year?
correct, correct. So you'll see in a moment how they come together.
The only one I was able to, that's a little confused. We were short, but here we're above.
So there's multiple categories in the Medicaid supplemental. You have disproportionate share, which is where we were really short this year. Oftentimes then some of that is made up in the uncompensated care. Those are the two largest categories in Medicaid supplemental payments we get. Those are payments outside of the per encounter payments we get. We also get payments for Atlas, Africa, and some other smaller programs in the state. So we did have a big reduction in DISH this year, 60 million, as you remember. And then when they did the uncompensated calculation, the final one this year, we had a $20 million increase from what we had anticipated. Those oftentimes, they're not one for one flipping, but you'll see a decrease in one and an increase in the other.
And when did we run about $20 million compensated care?
At the end of August,
That's fairly information.
yes.
So if you add all those supplemental Medicaid items together, it's about 120 million that you're budgeting for 26.
We're budgeting 120 million for uncompensated care alone. Yes, which is what was final settled for this year. So we are assuming we'll get the same amount next year. We might get more, we might get less, but that was our best assumption based on the changes. Okay, that answer your question? Thank you. So I don't want it to flip too fast. This is the income statement. It is in your packet. You'll see, I'll focus on August really. Net patient revenues were up about $1.5 million. Most of that is volume, but we were down in our payer mix. We have been experiencing an increase in volume. We were seeing commercial flat in that increase in volume, so we would see an increase in uncompensated care and self-pay. This is the first month where we've seen a decline in commercial relative to the whole book of business. So the volumes are up, the rate is down, we're still a little favorable on net revenue because of that. The next line, Blake, to your point, the Medicaid supplemental fundings, we are $3.4 million favorable for the month. But remember, there was a negative $7 million in there because we were short of budget by $7 million for DISH. But then we got another $12 million in for the uncompensated care that we recognized.
So there were 12 million negative for this just for August.
7 million for DISH just for August. So at the end of July, we recognized the shortfall in the DISH, knowing we would not get any more recognized for the rest of the year, but we had budgeted 7 million each month. Okay.
Is it paid monthly?
No, but we know the amounts, so we recognize them.
Kim, for the uncompensated care, is it possible for us to categorize them by surrounding county that we don't get reimbursement for?
So are you looking at patients that we see who are from out of county that are uncompensated? Mm-hmm. Yes, we have that in our revenue cycle data. We can bill the other counties if they have a county facility for those patients.
Because I have some preliminary dialogue with Dallas County. They have the same problem with surrounding county. And we try to see what's the impact for both the county that we're supporting, county that are not pulling their share.
Right, so we are looking at all of our payer sources and our patient populations, particularly in the uncompensated and self-pay area right now. Mm-hmm. So we can bring that back, but if you can give me a little time to take a look at that, that would be very helpful since I just finished the budget.
Is Dallas County billing us now?
No, and we are not billing Dallas.
Between those two, probably a wash, but it's the surrounding one is the problem.
Right, and I'll work with Rick on that.
I
The
would say the
CFO.
most calls I get are some of our cancer patients in Tarrant County that are being treated there. So to your point, I think we want to be careful, because we probably, as DT said, it's probably a wash.
It's a wash there, but it's the surrounding county.
The surrounding counties don't have necessarily the county hospital in order to fund for those patients, so they don't have that allocation. And so we're continuing to look at that population. How we find them funding sources is one of our goals, whether it's through a Tarrant County resident or whether it's through a different Medicaid funding or some sort of ACA funding.
Could we go to surrounding counties and say, hey, we're happy to help with your patients, but we just have to?
Only if they have a hospital that's funded, that's seeing those patients.
There's no,
They don't necessarily have uncompensated care.
They don't have an ad valorem supported program like Dallas and Tarrant County.
Oh, and they're not supporting their local hospitals that are
Correct.
located in Macomb County. for uncompensated.
Correct. It's unique. If you have a county hospital, you're very lucky for your county to have a county hospital to take care of the residents of your county, but it's very few in between across the country that there are these situations.
Do all counties in Texas have some legal responsibility for uncompensated care, or just the big counties?
Every not-for-profit hospital in the country has responsibility for uncompensated care. It's part of your charity, your obligation for being a not-for-profit hospital, whether you're county or private.
Do the counties have the obligation to arrange for the care?
It's all county-driven.
it's a different discussion once we have the data. So.
Yeah.
Well, it is a different discussion, but if the county has determined that they have a county hospital, whether it's Cook County in Chicago or it's another county facility, that county has made the decision to take care of their residents. And that facility is taking care of those residents. So not every county in Texas or every county in the country is required to do this.
Are they not required to do something?
No.
And so they can have a city and they have no responsibility, nothing.
I can use an example, like, I'm not going to use Tarrant County because it's too close here. But let's say Dallas County. There's no reason for Collin County to set up a hospital district when they can get away with it. So.
All right. So Medicaid supplemental funding is a great resource for funding that we do get for taking care of our uncompensated patients, our Medicaid uncompensated patient or low compensated patients in our facilities. Retail pharmacy, we've talked about, that was break even this month. However, it continues to outperform for the year. So we are over on our revenue. Wages are slightly over for the month. That is volume driven for the month. We've done a great job in eliminating contract labor, which means the premium on contract labor is gone, and we are also have reduced our use of shift incentive. Benefits look favorable. Benefits are primarily due to the pension that is positive through there. It's about 1.2 million of that variance, and so we have been seeing the pension under budget for the year. And then we look at non-labor expenses. We are favorable. Primarily depreciation is the biggest point. That is just timing of capital spending and getting projects online for the year. The other one you may see down in non-operating is the ad valorem. We are slightly under budget. That's due to successful appeals by the property owners for their taxes. And then investment income continues to outperform what we had planned for this year, the majority of it hitting this month for the unrealized gains that we've seen. I do have a new graph that I inserted for you that we will look at as we move forward into the new year. This is operating income, including ad valorem, budget, actual, and prior year. Prior year is green, blue is current year, red is the budget. This is cumulative, so October will be boring because it will be the same. So, but as we move forward, you see August, we're performing slightly higher than July, which means we performed positively. But we'll show you how we're comparing to budget in prior year. Last year, again, as I had mentioned, we had some additional adds to our performance, as I showed in the prior presentation. The next page, which we will do year-to-date and month-to-date, but right now it's just for the month. Starting in the new fiscal year, we'll do both. This reconciles for you the key drivers of performance, taking it from the budget to what I call a run rate, or the true performance of operations. Then we look at the one-time things not related to the month or the year, if we're looking at the year, to the actual performance. This is in millions, because I want to make the numbers simple so you don't get too many zeros on here. But we had a budget of $2.6 million this month for operations. We had a reduction in the rate, we had an increase in volumes, in the retail pharmacy and other revenue performing, the ad valorem. There's the supplemental Medicaid funding negative that's mostly related to the reduction in DISH. Wages and benefits favorable, most of that the pension I mentioned. Professional services, just some of that is timing. Some other, which is a bunch of little things, and I'm happy to highlight those if we need to dive into that. The physicians were on target, and then the foundation on target. From an actual run rate perspective, though, we were slightly in the negative at negative $900,000 for the month, or 0.9 million. Then we had the supplemental uncompensated care funding we received. The 11.6 is related to October through July. So then we had a $10.7 million performance for the month, but the actual performance for August was that minus 0.9. So everybody kind of following what I'm trying to show you is to really, how did we perform for the month? What were the unusual things that hit the month that would be potentially non-recurring or didn't belong to the month?
Okay, so 11.6 million in supplemental funding for 2 months, August 25 and October 24?
No, that is for October of 24 through July of 25. So it's related to the 10 months prior to August.
And then a chunk of that applicable to August, you have
In that minus 6.2. So that minus 6.2 has just over $1 million related to the rest of that.
and can we tie that number back to your previous income statement? Is that
The majority of it can be, some of it's moved around a little bit, so. But these are, really for me, is what are the key drivers that are causing us to perform the way we're performing. Sometimes when you look at income statement lines, you're not looking at all the lines that need to go together. So for example, if you looked at physician compensation and you don't look at the revenue or the staff that they're bringing in, you're not looking at the entire picture of what it's contributing to the organization. So you will find from me that I will try to tell you the story and the reasons behind, not just the math behind the performance.
in the rate mix, negative 5.3 million, is that the drop in commercial?
That's the drop in commercial. We're seeing an increase in self-paying connection patients.
That's significant for 1 month.
It's very significant for month.
The driver there you can point to?
Not at this time. So this will help, I think, you as a board understand the key drivers as we move forward and showing you this schedule each month. You can refer back to it because it's posted on your portal if you need to look at it.
Did we see decrease in volumes in the month of August?
We did not, and that will take me,
It's just the payer mix that changed, not.
right, so if I go forward, this is super busy, I know, because it's out of the performance report, but I blocked off. If you see at the very beginning, you see inpatient discharges on the very first line up 4.9 and outpatient observation cases, so we're up. It's the type of patients and it's the payer mix of the patients that we're seeing. The payer mix is at the very bottom of this. You'll see that commercial is actually down lower than we've been year to date. And so we're starting to see a little bit of decline in commercial going on. This page shows you the key operating income or indicators. Operating margin with the ad valorem is 5.7 for the month, about 8.5. We're probably going to end up about 7%, maybe 8% at year-to-date because we have some adjustments to make in September. There's some positives and there's some negatives as we look at the balance sheet and some of the year-end adjustments. For example, one would be the arbitrage on our investment earnings related to the cash we have from the debt. We cannot make more investment income than we're paying in interest expense on the debt. And that arbitrage calculation is done in September. It's going to be just over $1 million adjustment that hits the financial statements, for example. So we have pluses and minuses. I can't tell you for sure how, I'll know in about a week and a half what September looks like. Yeah, we have to pay it back.
If you earn more interest, then you pay that to the IRS, is that correct?
But no, I'm not sure you pay it to the treasury. I think you pay it through the debt holders. I'll research that, Blake, and just double check it with you. So, with the group. So, where is it going? So the operating margin without the ad valorem continues to be below 30%. We expect to be about 26%, probably similar at the end of the year. I will point out that overtime, which I see is right at the crosshairs, continues to be flat at about 4.5%. We have opportunity there. However, we would rather be paying our employees overtime than contract labor. Contract labor takes away from the patient experience. And so we want to make sure that we have people who are here who live and breathe the mission of JPS. So contract labor, which is necessary, but we want to make sure that we use our employees as much as we can. And it is less expensive to use overtime than it is contract labor. So, all right. Talked about volumes. We have the financial goals. These are the 10 goals. They're now in color for you. If it's meeting stretch, it's in green. So you see 8 of the 10 are meeting stretch. One is between actually target and stretch, so it's at target. And then the length of stay right now is not meeting threshold. So 9 of the 10 are at target or higher, and we'll continue to work on length of stay. As we've talked about length of stay in the past, one of our biggest challenges is placement of our uncompensated care patients. Go to long-term care, rehab, but they need home care or DME. It's a big challenge. We also have a shortage of long-term care beds in the community, and so trying to place patients is an opportunity that is very hard for us to meet, but we're continuing to work on it as an organization. We've made great strides in our partnerships on this. All right. Any questions? Sorry, there's an appendix to this.
No question, entertain motion for approval. All in favor, signify aye. Any opposed, motion passed. Thank you, Kim.
Yep.
Good afternoon. I have 3 contracts for your consideration for approval today. The first one is an amendment between us and Medline. Medline is our primary distributor for medical surgical supplies. It's a $50 million contract over 5 years, 3 years with 2 one-year renewal options. And essentially under Vizient, you're allowed to locally negotiate these contracts. So we renegotiated, and this contract will deliver about $500,000 in savings and price reductions. We also negotiated to avoid tariff and a few other fees that were in the existing agreement. Any questions?
Remind me again on Vizient contract. Do we
Say it again,
get
sorry.
share back with Vizient?
Yes, there is a rebate with Vizient. We have a GPO agreement. I think it's around 67% share back of the admin fees that Vizient collects. The admin fees that Vizient collects is usually between 1.5% and 3%.
I want to thank Charlie for really being very assertive with this renegotiation, something that we had not done prior, so be able to do that and create some savings.
Thank you.
Much appreciated, thank you.
We still need to sponsor a table at the gala. No, just kidding.
Yes, and, obviously, we're going through an M4 implementation, so getting this done will provide immediate savings and allow us to focus on the implementation next year. So we did use the timing strategically to make sure this got done, and we could realize those cost savings now and also avoid many of the tariff increases that were coming through.
Couple questions. The 50 million, that's an estimate based on supply usage, or is that a fixed price?
That's based on our annual med-surg spend each year. So we have about 10 million in distribution spend each year with Medline.
Okay, so it could be more or less depending on usage?
Correct. Yeah.
Can you estimate what, before this new contract, what would the 10 million have before the old price?
The price decreases is about $450,000 a year. Every year for non-contract products, you typically get price increases as well. So it's hard to say based on that annually, but that $500,000 price reduction should be for the life of the agreement.
Almost 2.5 million.
Yeah.
Savings, and that's for certain products that appear to be right. So for some things we don't have.
Yeah, so if you think about, essentially, Medline's our grocery store, right? Many of the big categories we negotiate individually with those manufacturer pricing agreements through a competitive bid or through our clinical value analysis teams. But there's a lot of low tail spend that don't have a lot of volume that typically get ignored. So, and some of those products are made by Medline. So what we did is renegotiate all of kind of that tail spend to get fixed pricing in place to ensure that all products we buy from Medline have a negotiated price.
And this contract's not with Vizient, this is with...
This is a Vizient contract. Most GPO contracts with Vizient allow for local negotiation.
Okay. Who's the counterparty between us and Vizient or us and Medline?
It's a locally negotiated Vizient contract between us and Medline. So we do put this on our paper. But essentially, Vizient did the competitive bid, right? But again, most GPO contracts allow for local negotiation, and we try to take advantage of that whenever we can.
But the counterparty here on the contract will be Medline?
Correct.
And what's the exit?
It's without cause. Typically, we have a notice period. We can exit the contract if needed. The distribution market is pretty limited. There's only like 3 big players in the distribution market today, similar to grocery stores on the retail side. Medline has a brand new local warehouse. They have a lot of capabilities. We did, before we locally negotiated this, we wanted to make sure we did have some discussions with the other distributors. Some of them are having some challenges. Owens & Minor is having some challenges. Concordance is a fairly new one, and they built a new DC, but they don't have a lot of capacity to support us. So, this was the best value for us at this time.
Did those other parties work with Vizient also?
Yes. Yep.
So we have some newer board members here, but even the older board members probably could use just a couple sentences about Vizient and what they're doing.
So Vizient is our group purchasing organization. There's 3 or 4, there's been a lot of consolidation in the healthcare market, but Premier is another large group purchasing organization. Health Trust is another one. And then Vizient. Vizient used to be MedAssets, which DT knows, Broadlane, and the old UHC Novation, which is a lot of university health systems. They combined and became Vizient years back. But essentially, every healthcare entity is a member of one of these group purchasing organizations. And you can imagine each hospital doesn't have a large sourcing and contracting team. So, and a lot of hospitals like us don't have multiple hospitals that can drive volume. So we're relying on these group purchasing organizations really to get us volume pricing for the commodities that we buy. And most of their contracts are the routine goods and services that healthcare organizations buy. But also, many of their contracts allow for local negotiation, so we can drive better value in pricing if we negotiate that. And depending on what the category is, there's often opportunity left on the table that we can further drive value, such as this instance.
And the mayor just announced they're acquiring one of their competitors this week.
They also announced that they're going private again. They went public years back, and they just announced that they're going private as well. Sure.
Charlie, so they are the primary GPO for?
They are our primary GPO. In most GPO contracts, you have an exclusivity with them. You can't contract with other GPOs. So you almost have to pick who's your partner. We do use Vizient on the the clinical side as well. There's some value of having the quality tools aligned with our contracting tools to kind of combine that data to get a better picture of what's going on from a health system perspective. So.
Are they helping us with PPI, or we do it in-house, and how we do it on PPI?
So the Vizient contract is potentially coming.
You might want to explain PPI.
Yeah, so PPI is physician preference items. So they are implants and things used for specific surgeries and physicians that really you have to have the physicians involved when you're going out to market for those. And there's lots of nuances between each PPI category, but we typically separate that from commodities because they are so clinically driven by what we're doing, the type of hospital you are. There are some strategies, when you can imagine a large health system with 42 hospitals, it's hard to standardize your cardiac rhythm devices because there's lots of preferences. But, us being a smaller hospital, one hospital, and not as many physicians in each procedure, those are things that we're going to be looking at and seeing if we can drive some cost benefit and standardization for physician preference.
Thank you. Any more questions? If not, entertain motion for approval. All in favor, signify aye. Any opposed? Motion passed. Next item, Charlie.
Okay, thank you. The second contract for your consideration today is a contract with Bone Support. Bone Support is the company that makes a proprietary, newly FDA-approved item called Ceramint G. It is a bone filler. This went through our clinical value analysis process. We did do several case studies, and what it will do is it will allow us to reduce readmissions or a second visit with patients. So better for the patient and also better from a cost perspective. It's about $350,000 a year. It is a 5-year agreement. And again, it is a newly FDA-approved bone filler.
Is this for orthopedics or for dental?
It's for orthopedics in specific scenarios. I don't want to get too clinical, but it essentially will fill a void that typically you have to let it heal on its own, and then the patient would come back and do a second procedure. So it's one instance for the patient and prevents that second visit.
The healing and everything else. Thank you. Any questions? If not, entertain a motion to approve, including exemption also as well. All in favor, signify aye. Opposed, motion passed with the exemption.
Great. The last contract is another exemption to bid with a company called Onco Surgical. This is a 3D custom implant for the pelvic joint. It is new technology. It's a 3-year agreement with 2 1-year extensions, total 5 years, around $450,000 a year, $2.25 million per year. Essentially, on certain cases where there is pelvic joint damage, it can do a 3D implant and help with the reconstructive process for the patient.
Is this including loaner tray for tools or without?
No, this is specific to this newly approved 3D implant for that procedure. And again, it is in certain cases that the physician deemed necessary. It's not going to be widely used. It did go through the clinical value analysis process.
Is this for use in ASC environment, outpatient type?
I'm not sure. I would think this would be inpatient, but not sure, but I can find that out for you.
That's all the medical stuff I can ask.
I'm not sure.
Any additional questions? If not, a motion for approval
All right, thank you.
as well.
Yes.
Thank you all.
Second, all in favor, signify aye. Aye. Any opposed? Motion passed. Thank you, Charlie.
Thank you.
Mr. Brian.
Brian's going to present this particular contract, but before he does, I just wanted to provide some context. This agreement is to build out some of the shell space we have at Medical Home Southwest. Just as a reminder, that shell space at Medical Home Southwest was approximately almost 5,000 square feet, so this is a 2,800 square feet build-out. Based on our FY25 budget initiative around growth for specialty pharmacy, Kim just spoke about that. We are, $13 million above budget for specialty pharmacy. This will allow for a build out of that space so we can continue to grow. Currently, we do specialty pharmacy volume at our Oncology and Infusion Center, as well as our Viola Pitts Center as well, and so this will allow additional growth. As part of that budget initiative and kind of that roadmap to continue to grow, we also were going to obtain our URAC accreditation for specialty pharmacy. I'm proud to announce we had a very successful visit on September the 11th. We had no findings, and so now we are just waiting for that official notification that we are accredited as a specialty pharmacy by URAC. What that will do for us is allow us to contract with additional payers, as well as get access to additional limited distribution drugs. And so this will allow for that additional growth in specialty pharmacy, which we know is an additional revenue stream for us.
All right.
This says one-year term. This is the entire construction cost?
It is.
So it's really, once it's done, it's done.
Exactly. We're looking at probably completing in June of 26 is when we will actually go live. And so we'll start, at the beginning of the year, and we'll have our construction phase and about a 30-day move-in for the specialty pharmacy.
How many square feet is, you may have said it.
Yep, this will build out 2,800 square feet. We'll still have about 1,300 left of shell space at the new medical home.
So this is almost $400 a foot in build-up cost, is that right? That seems kind of expensive for building out shelf space. Does that include equipment too?
It does.
Yes, it does.
Includes everything.
Design fees, equipment,
That's turnkey.
yes.
Yes. Flip the switch.
Any more?
Say why we need the specialty pharmacy at Southwest specifically, or is it just?
We have space, available space there to build out.
Will this drive traffic down there, or is this big?
This is mail out.
That's,
Yeah,
We're
yeah,
just using this space we have.
exactly, yep.
No more questions? Entertain motion for approval. All in favor, signify aye. Any opposed? Motion passed.
Can I say one more thing about that one too? I mean, 5 respondents to the RFP seems good to me, because what we feel good about that, and we think that's, because we've had times where nobody.
Correct.
Maybe we should.
So the second contract being presented this afternoon for approval is with Johnson Controls Fire Protection. This falls into the category, if you recall from the previous meeting, a grouping of maintenance contracts. This is based on an annual historical spend, and this provides the fire alarm programming and technical support to our fire alarm system throughout the hospital for the next 3 years.
Any question? This require exemption also as well.
Yes,
Do you have any, this is for 3 years, and this is a renewal basically, if
correct,
they're already servicing it.
correct. It's a proprietary system.
530,000 compared to like the last 3 years cost.
That's exactly what this figure is based on. It's an average over our last 5 years historical spend with Johnson that come in when there's a problem with the panel. They come in, troubleshoot, repair, replacement parts, reprogramming, whatever is required for the failure that occurs.
So this is not a fixed price contract, this is
No, it's on an as-needed.
estimate, and you're assuming no increase in cost over the next 3 years.
Correct. It's in the pricing. I think there is a slight increase annually, year over year. So it's not 530,000 divided by 3. There's a slight increase for CPI increase over that 3-year period. Certainly.
We're going to vote now. All in favor, signify by aye. Any opposed? Motion pass. Next item, please. G.
The next item up for approval is another similar contract with Sunbelt Rentals for equipment rental. This is, again, based on historical cost, 3-year contract, almost $750,000. And this is for routine and emergent equipment rentals. Sunbelt is the only local vendor that provides everything we need, from temporary air conditioning units to man lifts to generators, forklifts, chillers that we need from time to time to keep services open when there's a failure.
So do they have to bid against anybody else, or they're just automatically chosen?
On this one, this was, Sunbelt is the only vendor locally that has everything we need. There were competitive bids, but this was the one vendor that could support everything.
Yeah, it was an
There
RFP.
were 5 respondents to the previous one, but there were no, you didn't put how many that Sunbelt, Equipment Share, United Rental, did any of them go after this?
I can't tell you the details, but what we did is provided the list that we needed. Sunbelt was the only one who could fully respond to every item on the list.
We will put that,
To Tim's point.
yeah, we'll put that in moving
Yeah,
forward.
to Tim's
yeah.
point, you know, historically, we could get one bidder, and then people just go ahead and bid on that person or that company. So I think if it's gonna be open and fair, if there were 3 or more, or multiple, it should be listed on here.
Certainly.
Our report only deal with one rental company. If this company has 5 of what we need, this other company has another 5 of what we need, we can do a mixed contract. Say, since you have this equipment, and you don't have all that, but you have some of it, mix and match. Also, quality equipment, the ability to turn around and service equipment, that's one of the things I've noticed with other companies in the past. They might have a lot, but their service on the quality is limited.
Well, I can tell you our experience with Sunbelt has been very positive on response. To answer your first question, I would say it depends on the dollar amount involved, right? So within our purchasing guidelines, if it was significant, we would have to go to an RFP to go outside this contract. But we could go through that process if required. Usually, this is I would say normally this is a urgent or emergent need where something is broken, we need cooling in an area to keep patient services, we can get that delivered in the time frame required to keep services open. That's the basis of this contract. For those urgent needs.
Relationships also.
Yes, we do.
Motion for approval. All in favor, signify aye. Any opposed? Motion pass. Next one, Brian.
The next contract is the sale of property at 820 Uptown Boulevard in Bedford. This is a sale for $300,000 to the current site. That is the appraised value of the property. anything more to add on that one unless there are questions.
Do you have any history of this property? Not somebody you're from, just what it was?
So it was the old Northeast Medical Home property, and the building's still there. It's pretty much condemned with.
Yeah, we, just to maybe add, Dr. Duncan, what you're saying, so we did look at the opportunity to demolish the property. It was there. It's in very poor condition. It's not usable for patient care or business purposes today. And the value to do the required asbestos abatement and demolition was almost $500,000. And the buyer is taking property as is.
We attempted to sell it with the building on it because we knew the demolition cost was high. So we attempted to sell it with the building on. It's been very difficult because we moved into the Northeast Medical Home, 2017. And so we've gone through different iterations of, contract on it, not going through. And this has been the most recent and more reasonable price for this property and for that building. We do get cited often just because that building's sitting empty, and so we really want to get it off our hands. It's been empty since 17. We've evaluated it to see whether we need it for future growth, whether it's a new medical home or outpatient surgery, and we do not feel at this time that it's needed for future strategies.
There was another contract on this property a few months ago that fell through.
That's correct.
Yeah, I believe it was, yeah.
Yep.
Yeah.
Sold on the agenda and then it dropped off.
Yeah,
Correct.
so we're hoping this one goes through.
Do you know what they're planning to do with the specs?
We do
We
not.
don't.
Supercharging station? No, I'm just kidding.
And we don't even know if it's the same Tesla. Yeah, we,
Spirit Halloween and a magic world cloud this building, so maybe it's a magic.
Move to approve contract, sale of property.
yeah,
Any second? Tim second.
get this approved and just get.
All in favor?
Oh, sell it for $1.
CDP aye. Are you sure? Any opposed? Motion passed. Thank you, Chuck. Thank you.
Thank you.
Hello, Ashley. How are you?
How are you?
Good afternoon. I have one contract before you this afternoon. It's an exemption to bid in the Second Amendment to a professional services agreement between Tarrant County Hospital District and Clinton Rubin. Clinton Rubin is a professional services company that is providing us with the consultancy services for our payroll portion of the M4 implementation. And so this consultant has been with us since March of 2024, and she will remain contracted with us through the implementation of M4 and has been extremely instrumental in our payroll implementation portion of the HCM.
Any questions?
What is the loss of M4 project? What does that do for?
So our M4 implementation, which is our enterprise resource planning tool, we've talked a lot about M4, and so today we're processing payroll on Lawson. Really old system, really antiquated system, and so there is a lot of work that has to happen during the implementation to get our processes, our data, our audit processes up to the standard that we can actually implement it into M4 and process payroll. And so this particular consultant was literally a needle in a haystack and has spent about 30 years helping organizations do just this, and so we will leverage her for the implementation. And then once we've implemented M4, she will roll off.
So the loss of M4 project is like an application.
It is our payroll system today. And so it's what we would call legacy M4. So back in the day, Lawson became M4.
So Infor is our ERP, so it's HR, supply chain, and finance. So it'll be the general ledger, HR functions, payroll, and supply chain, including contract management and procurement. So,
Benefits will actually be part of that as well.
yes.
We have a very outdated version.
We have a very outdated.
Trying to get this group to bring it up to speed.
Well, they will come alongside us as we bring all of the HCM, so human capital management product up to speed. Yes.
This didn't include the licensing cost software, that's.
It does not.
This is to bring us to the latest, I guess, the version.
We are going to the cloud for this version, so this will be one of our journeys to the cloud. We have 2 core systems. We have Epic for the clinical side of the revenue cycle side of the business, and we have Infor for the business side. Those are our 2 core systems to run the business. So we have a consulting group called Impact Advisors that's leading, and the 3 towers of finance, supply chain, and HR all have subject matter experts. And what Ashley is proposing as this contract is for is the subject matter expert for payroll for the implementation.
After the 2 years, will you still need the services?
We will not. Once we implement Infor, we should not need her services.
Yes, sir.
So, first of all, thanks to Ashley for talking to me about this earlier, and thank you for this hat. I'll not put it on in case somebody takes a picture of it. Ashley and I grew up in the same small town. We're the same age, although she looks 10 years younger than me. And so she went home and bought this hat back. So thank you.
Yeah, see the hat, too.
So Paducah is where we grew up.
Yes, Paducah.
Where is that?
This will be an inside kind of thing with you.
I'm sure you would call it. So this is one person, right?
It is one person.
And part-time?
She's part-time.
So I guess the only, I mean, I feel obviously we gotta do our payroll and everything, but I think, and we talked about this a little bit offline too. I think if we're gonna start outsourcing payroll in the future, if you feel like that's what we need to do, I think the encouragement that I think you would say, otherwise it's for us, would just be let's move that along. It's a lot.
So as we shared before, it's the process, right? And so there are certain steps that we need to take. I've said to you many, many times before this HR committee and before the board that, you know, when we started this project, we were probably somewhere in 1996, and we're moving along into the early 2000s. But part of the work that we have to do to be ready to determine, and ultimately that would be something that Kim and I would make a determination about it, whether it would make sense for us to use a processor like an ADP or a Paycor. But part of the journey for that is for us to get on a system that will allow us to even have APIs and other technologies that we need to connect to that. And so this is kind of the next step. This is kind of a one-time thing, right? We need the support to be able to get our processes, get our processes, and all of the Infor implementation and design built, and then she goes away. But ultimately, as you all know, consultants that are good cost, and this is the right solution for us to ensure that when we implement Infor, it is usable, it's functional, and we can move forward with our payroll and our HR strategy.
Yeah, we just don't have the expertise
It does not
in-house, just because it is new for us, and Ashley and I have had that conversation of how quickly, to your point, can we hand this expertise off and take it on ourselves, so.
I just think, I hope that some of the HR will take a look at it and prioritize it, because I think there could be some savings.
I guess one of the questions that's saying to me is that it's not a set fee that it is determined, so it's determined by the user.
Yes, so we pay by the hour, and it's cyclical, right? I would say in the beginning, we used a lot of resources and, you know, through the heavy parts of the design phase, but as we start to ramp down, those hours will ramp down, and we will have a second phase, and we will perhaps use those services again, and it will be cyclical. I can guarantee you all that I watch this like I'm watching my own checkbook, and so we are not overutilizing services. We are being really thoughtful about how we plug her in, and we are really focused on utilizing her for what she's needed for and not for things that are routine, things that our team has the expertise to handle. We're moving.
We are
forward.
halfway through the project to go live in June. So we're 9 months in, another 8 months to go.
So just to be clear, this is raw, right? June 530.
Yes. Yeah, you may not use it.
Ashley, you mentioned she was a needle in a haystack. How did you find this consultant?
So we actually worked some of our channels. We started asking around. We actually, I had a couple of colleagues who had done some M4 implementation, were M4 certified. And then the other thing is that we reached out to, I feel like our broker may have, so we vetted a ton of people. I mean, it took us a while to find her, and she just had the unique combination of experience that we needed. Like I said, she's pretty much done this work for a long time, and so I will tell you, when we found her, we thought it was gonna be for shorter term, and then as we got into really disclosing where we had skill gaps and really what we were undertaking, we understood that we needed to keep her on for some additional time. It was a good find.
Is she from the small town too?
Not that I know of.
We'll be wearing,
But I will tell you, most phenomenal people are from small towns.
she will be wearing that hat
Yes.
too, watching, we'll know who she is.
$175 an hour, I believe, is what I saw, the base rate, yeah.
And that's just basically county hours.
Say that, I'm sorry, Blake.
Your total here just is estimating the number of hours that we need to finish the project.
Yeah, well, so I actually asked that question of my team, and so she's averaging right now about 28 hours a week. That's what, right now.
Since it's an HR related, would you like to make a motion? You forgot the exemption.
And I'll second it.
All in favor, signify aye. Any opposed? Motion
Thanks.
passed. Thanks, Ashley. Next item.
Thank you. Thanks, Lonnie. We actually brought this contract last meeting. I'm bringing it back because to allow the board more opportunity to review. This is our interlocal cooperation agreement between Tarrant County and Tarrant County Hospital District for correctional health services. There are no dollars associated with the agreement because we actually budget the services in our own budget. We worked with the county to get this in place, and I do believe that they approved it at their last meeting. And now that you've had an opportunity to review the contract, I'll take any questions.
I don't,
Yeah.
I reviewed it, I think it's, not only is it a good contract, it's what we need. I think it was Dorothy and I talked about before, I think we need to make clear what we do, and we need to make clear what we don't. And I think this contract does that, and, as much as, this is an absurd statement, I would encourage the public to read this contract, because I think it's important as it talks about what I just said, what we need, earlier, and that's with respect to everybody that works over there. It's an important job, it's a tough job, and, it's been excellent by the community.
No, thank you, Tim, for taking a deep look into it. And would you like the honor to move the motion? All in favor, signify aye. Any opposed? Motion passed. Before we take the vote on the next two agreement between the hospital district and the county for the funding of certain county-wide services, I want to take a moment to address the board questions around the rationale for these agreements. You recall the service to which these funding agreement relate are directly between the parties providing the services in the county, so that the hospital district does not directly participate in drafting those service agreements. Tim and I had the opportunity to speak with our chief legal officer to discuss different options for opening the dialogue with the county about how we can collaborate better on these items going forward. I'm planning to meet with the board officers so that we can begin discussing with our liaison on the court and the executive team. We'll get an internal work group together to discuss with these parties providing the service to get a better understanding for their needs. We will continue to report back to the board with updates on our progress so that we are in a better position on these items going forward. And finally, I want to sincerely thank Tim for his guidance in this matter. Tim, I know all of us will continue to lean on your insight and experience with this in the future. So thank you. So the next item is Ms. Walker.
Yep, and these are the two funding agreements that you were just referencing. The first one is the fiscal year 2026 contract between Tarrant County Hospital District, and the MHMR of Tarrant County for MHMR services. This is a funding for behavioral health and intellectual disability services to be provided to citizens of Tarrant County through the auspices of MHMR of Tarrant County. As Mr. Chairman Nguyen mentioned, we will be working with them to talk about solutions of these going forward, but for this year, we would like to ask approval of the $1,594,650 for the services that is included in our 2026 budget.
Motion for approval. Anyone?
I am glad that you are going to set up something to look at this, so I will move approval.
Thank you, Dorothy.
Second? Second, Dr. Holland. All in favor, signify. Any opposed? Motion passed. The last item.
We heard you and we will work on it.
Item L.
Yeah, it's a little bit more money. This is the second funding agreement. Consider approval of fiscal year 2026 contract between Tarrant County and Tarrant County Hospital District for funding of specified county programs. This provides funding for countywide behavioral health, intellectual disability services for the rehabilitative alternatives for probationers and parolees program, as well as public health services to the citizens of Tarrant County. We're asking for approval of $22,885,458 for these services, and that is included in our fiscal year 26 budget.
I'll comment on this. We do need to look at moving this entire item to the county to fund Tarrant County Public Health Services directly. Until that happens, out of my great respect for Dr. Brian Bird, I will move to approve this funding for this year.
I'll save the second to a new board member. Would you like to second that? All in favor, signify aye. Any opposed? Motion passed. One.
It does have your quarter of, we get a quarter at a time.
I do. I appreciate that, and I want us to move forward. I just want to be on record that we talked about it, so I'm glad we're moving forward. I still don't think that.
You're not going to change your vote, are you? Are you good with your vote? No. Okay. Do we have anything in closed session?
We do not have anything for closed
We
session.
do not have anything in session. I just want to take the opportunity since to thank our former board chair of the board, the former chair of the finance committee, and he's also helped us tremendously with the master facility plan and the blue ribbon and all that stuff. So we'd like to thank Trent Lott, not Trent Lott, sorry. Trent Petty for his work, and really appreciate his dedication for many, many years of serving on the board, and would like to welcome you on board also as well, Casey. Appreciate it. The meeting is adjourned.
I know. Dorothy?